the concept of welfare state? Richard.
A welfare state is a state that is committed to providing basic economic security for its citizens by protecting them from market risks associated with old age, unemployment, accidents, and sickness.
Okay, thank you. A state that is committed to provide some form of economic security for all its citizens and catering for things like old age and employment. You talked about what else? Accidents, issues to do with accidents. So the most important idea with the welfare state is the realization that if we pursue a market-led economy where forces of demand and supply determine the provision of access to goods and services, provision and access to goods and services, just those would have access to the population that is going to be. There is going to be a huge section, not out of their own will, that they are lazy, that they don't want to work. They are just pretending. There are issues to do with people who are aged, like you mentioned, old age, people who have been laid off not out of their own choosing, but because things have changed and they are still either they have been laid off and they can't be able to get into employment, or they have a period of unemployment. Those who are ill, those who have been involved in accidents, are those who the children who can't be able to enter the labor force and be able to sell their labor. So there is a huge section of the population that is going to be left behind in terms of earning income and being able to demand goods and services and be able to improve their lot. So in essence, welfare state says we could provide basic minimum in terms of things like health care, universal health care, nearly for universal health care for all, or education for all. We are talking about, for instance, UPE, if education for all. If we had quality universal primary education, it would have impacts, positive impacts on population health generally. If we had quality universal health care for all, we would expect that population health generally would improve. So the commitment to ensure that not that very few or none is left behind in terms of economic progress, in terms of warfare. There is also a commitment that heavy inequalities between citizens is going to be, it's not going to be beneficial for anybody. If we have a population where very few are extremely very rich and majority are in extreme poverty, it doesn't help anybody. At the end of it all, it is even going to catch up with those who are extremely very rich and lead to the state of affairs. So in order to improve population health, and several of these indicators, childhood mortality, infant mortality, maternal mortality, provide some basic social services for nearly everybody in the population, such that those who can't be able to work are also catered for. In contrast, we'll talk about a capitalistic system. With the capitalistic system, the emphasis is on living a free market economy, where the forces of demand and supply are king, or determine access to goods and services. But in reality, what we have to notice is that there is no society out there. Majority of societies out there are going to operate a capitalistic system of some sort, and elements of a welfare state of some sort. So there is not going to be a completely capitalistic system or a completely welfare state out there. So majority of countries operate some form of both a capitalistic system that emphasizes a free market economy in the provision of services and goods. So those who have money will have better access in this to education, quality education, good private schools, and better access to health care, go to services, private wing of where they are well catered for. So, but the result is that many people in the population are going to be left behind in terms of access to good quality services that are health improving. We know that good quality education can to some extent contribute towards better health for our people. So some of the examples that we could have. So as an example, to make this clear, countries that operate a kind of welfare state tend to have less social inequality among citizens. And due to this, better population health overall. And generally, such countries tend to have social democratic regimes that encourage higher public spending and lower income inequalities. And due to these factors, have populations with better health. But in contrast, high-income countries that have pursued neoliberal approaches to economic policy have been found to have worse health inequalities and higher mortality rates. So it doesn't mean that when one is a high-income country, if they pursue a neoliberal approach to economic development, even in high-income countries will have worse health inequalities. We'll have segments of the population dying of preventable diseases because they can't be able to access good quality health care. We have segments of the population that are excluded from the education system, quality education system, and then high rates of illiteracy and high rates of poor health indicators. So in brief, that's economic and political context. So it encompasses issues to do with governance, issues to do with corruption, issues to do with inequality. You'll find that in some countries there are going to be high levels of inequality, while in others there are going to be limited levels of inequality. And in places where we have less inequality, we tend to see better population health overall as compared to places that have high levels of inequality. As simple as that. Questions, comments, questions on that make it much more clearer. Income, socioeconomic conditions, and socioeconomic conditions such as concentrated poverty. One of you should take the lead, read these two paragraphs. How many? They are two actually. Alex Ainemba was is the first person I'm seeing here, so read us in those two paragraphs. Alex. Is Alex there? Or he has signed in and disappeared. Alex has disappeared. Moses Masambira. Moses Masambira, switch on your microphone and you are reading those two paragraphs. Wada?
Yes, Doctor, can you hear me?
Yes.
Yeah, I'm reading. So the first paragraph says we are on income and socioeconomic conditions such as concentrated poverty. So the first statement is poverty is the single largest determinant of health, and ill health is an obstacle to social and economic development. Poorer people generally live shorter lives and have poorer health than affluent people. This is according to the World Health Organization, NDB. People with limited or no income usually do not have adequate resources to meet the daily needs such as educational and job opportunities. So educational job opportunities, living wages, or healthy foods. So most of such people tend to live in overcrowded and poorer living and in overcrowded and poor living conditions, which then contribute to the spread of airborne diseases such as tuberculosis and respiratory infections such as pneumonia. That's according to Roberts 2018. Reliance on open fires or traditional stoves can lead to deadly indoor air pollution. A lack of food, clean water, and sanitation also be a risk factor for several diseases such as cholera, dysentery, typhoid, and so forth. That's according to Roberts 2018. So, marginalized groups and valuable individuals are often worst affected, deprived of information, money, or access to health services that would help people prevent and treat diseases.
Okay, thank you. So poverty is the single largest determinant of health. So take the relationship between poverty and health quite seriously. Like I mentioned also earlier on, take the social determinants of health quite seriously, because they form the cornerstone of what we discuss in sociology of health. So poorer people generally live shorter lives as compared to affluent people. Why is that the case? Poorer people tend to live shorter lives. Why is that the case? Kisa Kisa, you had your hand up.
Yes, thank you, Doctor.
Yeah.
As we have seen before, that the poorer people, number one, live in high populated areas where there is a spread of diseases such as airborne diseases and food water contaminated diseases. And number two, they are not able to meet certain needs like of medication and also having good feeding, or they are not able to feed themselves properly. So all these conditions try to shorten their lives. So even at times when they get these diseases, they are not able to treat them properly. So all these factors all together contribute to their having a very short life.
Laban.
Oh, thank you, Doctor. Just to add on what my brother Kisha said, people generally they have inadequacy of what, even in accessing the medical services, because at least they will not go for these medical checkups. If someone is poor, what I know is that they can even die with a disease and they don't know what has killed them, because they cannot easily access medical services and they don't even do medical checkups. And just as we have seen, they also have poor sanitation and they are easily exposed to the deadly infections, which can lead to what? Reduction in their lifespan. Yeah, that's what I can add. Otherwise, even what Kisa said is what I wanted to add to talk. Thank you.
Do we have other people with the hands up? There are people with hands up. Porupot, you had the hand up. Paul, okay. Paul or Porot.
It's not a report, it is a polot. Yeah, so in my opinion, generally, poor people have a low quality of life, stemming from just, first of all, inadequacy of finances to acquire the basic living needs, even just the food, the proper healthy living, and then even like things that keep them away from diseases, like preventing the acquisition of the diseases, is a problem that already exposes them to getting ailments and probably having a short lifespan. And then secondly, much as these people live in these poor conditions, even when they get the diseases, they don't have the enough resources to acquire proper medical attention. So that is my opinion as to why the poor people are always having a shorter lifespan compared to the rich.
Thank you. We generally agree that poor people live shorter lives as compared to the affluent, as compared to the rich, and you have done a good job to describe why. Issues to do with sanitation and poor hygiene Many poor people live in slums. In Bugonji, in Kampala, in many slums. Recently, they were being evicted from the swamp in Rubiji, and they didn't want to leave. So generally, poor people live in environments that are supportive of good health, and that make it much easier to be able to get some of the many infectious diseases. Somebody has a hand up. You are called who? Oh no, Samuel. Okay.
Yeah, I was inquiring, is it always the case? Because there could be some poor people having longer lifespan.
Is it always the case there could be some poor people with a longer lifespan? True, there could be some poor people with a longer lifespan, but what we are talking about here is largely more of averages. Poor children of poor people are likely to die during infancy. Children of poor people are likely to die before they get to 5 years. If we look at issues to do with maternal mortality, those in poverty are likely to register high levels in terms of maternal mortality. If we think about infectious diseases, because we know that infectious diseases usually kill in a short period of time. These malaria or dysentery, or it doesn't usually, if one is catches one, usually a short period of time, things are done. So on average, poor people live a shorter lifespan than the well-off. So you talked about issues to do with sanitation, nutrition, hygiene, and so forth. Daniel?
Yes, doctor. On that note, I would request you help me understand well the definition of poverty, because like we have some poor people who have been advantaged, they have got associations to help them, and so I think that's what is bringing about confusion.
So you need a definition of, so if maybe we could start from there. If you saw a poor person, can you be able to identify them? And this goes to all of you. How do poor people look like? Let's be quick. Well, how do poor people look like?
Generally, doctor, poor people, I'll speak on experience. When we were doing we visited some villages and some families, and you could reach at them and just know, first of all, they're miserable. And some of these people, they rarely get even a meal. You find someone is hungry, miserable, some of them, even their health is not so good. There are people who are poor really in the villages, maybe moved, you can just know that this is a poor person, because even everything it can tell you. Yeah, maybe that's how I can define some of them. Thank you.
Rachel.
Another thing I can add on what Laban has said, poor people live in poor housing facilities, like you find them in same permanent houses. So if you reach in a community and you see the housing, like the quality of housing around the village, you can really tell that these people are poor.
Using the yardstick of housing, poor housing. So generally, you talked about they are in misery, they are hungry, they can't be able to afford the basics of life: food, shelter, clothing. You find their children in either walking around without clothes or limited clothing. Food, we can't afford 3 meals a day. That's how we can be able to identify poverty. So we usually talk about absolute and relative poverty, but many times we are much more interested in absolute poverty. Being unable to afford basics of life. Others talk about being unable to survive on less than $1 a day, or even less than $2 a day. If one computes how much they spend a day, and they can't be able to spend more than $1 or $2 to be able to meet their needs, they would classify themselves as, and they would also be classified by others as poor. So poverty is the single largest determinant of health. So if what that means is that even when we are talking about other determinants of health, for instance, gender, for instance, education, will come back to issues to do with poverty as a mechanism through which these factors work. We know that those who are well educated tend to earn more on average than those who are not educated, and therefore we are talking about, to some extent, issues to do with poverty. And those who earn more can afford to take their children to school, can afford basic medical care, can afford to have nutritious meals. So in essence, we'll come back to issues to do with the income, even when we are talking about other determinants of health. So, but what I want you also to note is that poverty can be a cause of poor health, but can also be a consequence. Can also be a consequence of poor health. So it's positioned in such a way that how is poverty a consequence of poor health?
So, in my opinion, in a case where someone is having maybe a chronic illness that usually needs consistent medication, they will always end up struggling to, okay, they'll always spend whatever resources they have to treat the disease, and at the end of the day, they end up becoming poor because they've spent all what they have to try and treat the disease that they're suffering from. That is my opinion.
Okay, Emmanuel.
Thank you, Doc. A person is okay, a sick person or unhealthy person will be sick, and that is less productive or indulge in economic activities that will generate income, and therefore it will greatly contribute to poverty.
Okay, so we note that relationship and also take it seriously. Poverty can be both a cause and the consequence of poor health. Just like you've rightly pointed out, we are thinking about chronic illnesses or chronic conditions. Many require expensive treatments or keep a person in a state of spending. They are buying medicines for quite a long period, and we might end up selling all their land because the treatments that needed to be obtained. Sending, for instance, people are seeing many Ugandans being airlifted to Kenya or being referred for treatment to India. That costs quite some money. So if you are going to raise 200 million to take a patient to India, many families end up selling their property and moving into abject poverty. And remember, just raising 200 million is not just the starting point. They would have been in the healthcare system in Uganda for quite a long period of time, spending money to be able to treat a condition. But at the end of it all, the referral comes in. You might have some chances of survival or better outcome if you go to India for this kind of either surgery or this kind of treatment. And you have to raise 200 million or so to take the patient. And then at the end of it all, either they get to India and they die. And they have to be transported back in a casket. And that also costs money, because transporting a dead person is also expensive. Transporting them back. So at the end of the day, you might find the family moves into abject poverty. Even if we've heard of people selling off their land to bury their relatives, those who have died and there are no resources to be able to cater for the funeral, say, okay, who can be able to buy this piece of land so that will give this person a decent send off? That's a family moving into poverty, a family having their children scattered because they can't be able to. Most of the resources have been used to cater for a dying or a sick person. And that's became near a case when we had, for instance, HIV and AIDS killing off many Ugandans at some point in our history. When many people were dying, we had families scattered. Find the mother and the father have died. And some of the children were also infected through mother-to-child transmission. And they also need treatment. So the children get scattered, become orphans, and can't be able to obtain education. Land has been sold off to cater for the medical bills for the ailing mother and father and the children. And at the end of it all, the family disintegrated or is completely rust. So that's being sick and how rust contributes to poverty. So it has a bidirectional relationship. We can see that there is a bidirectional relationship between poverty and health. I think we can skip this paragraph. What is in there? Related to the above is the aspect of social class and inequality and its influence on health outcomes. Individuals in the lower social classes in several countries experience a wide array of health problems as a result of their economic positions. Persons in the lower economic classes tend to be unemployed, poorly educated, and to live in a poor housing. The poorest of the poor in developing countries are prone to diseases of poverty, such as cholera, malaria, dysentery, and so on. But in developed countries, however, those in the lowest social classes have a higher risk of chronic diseases such as diabetes, heart disease, and cancers. People in the lower social classes generally are unable to use healthcare as often as people of the higher status. And when they do, it's often of lower quality. So I think we can leave the relationship between poverty and health there, unless you have questions. And now we talk about gender. Questions?
Doctor, how do you explain this point of the poor being marginalized?
The poor being marginalized. What?
Yes, Doctor, me, I think that one I can easily explain it. For instance, in terms of accessing medical care, you may accept that when you go to the hospitals or those clinical settings and you are poor, even if they are government facilities, you are just left aside and they first work on these ones who can at least give in some money. That means it's like despising or marginalizing, letting down someone. Yeah, so, and even it occurs in almost every sector that is essential or that are service providing sectors. When you are poor, you not doing something, it becomes very difficult for you to get the wanted product or wanted service.
Okay. Robin wants to add.
Okay, thank you, Doctor. To add on Wada's thing, and I remember when you were starting this lecture, you talked of a government hospital having a private wing, and that one is a very big factor that can discriminate between the poor and the rich. Because now, if you reach here, and then you can have some money which can sustain you in the private wing, though it is a public hospital, you're going in the private wing to be worked on, and you mean you have to fetch some money. And so that is a marginalizing factor, according to me, just to add on Wada's statement.
Okay. I wanted to stop it there. Isaac?
Yes, Doctor. Good morning, class. I want to bring this example of a mother who has come from a remote area with a child having pneumonia, and RDC of the district who comes to just pass by the facility. You will find that when people get to know that the RDC or the LOC5 has come into the health facility, everyone is on his or her toes to see how best they can help that person. because they know the status of that person. When you look at the other mother who is from a remote area, who doesn't have money, she's not known by anyone, you'll realize that she is not paid attention as compared to these guys who may not even be sick, but they have just come to pay at a school. Everyone wants to pay attention to them. In that way, you find that the so-called poor people are always underlooked. Even the society, even if you have good ideas and you are poor, even if you raise your hand, no one will pick you to get you are what you want. Tell them you are always look like you have nothing to contribute in the society. Thank you.
Okay, I think taken together, you've explained what marginalization is about. Uh, so we can proceed and talk about issues to do with the gender and the relationship between gender and earth. We have two paragraphs and one person can ably. Remember, is she there?
Yes, Dr. Amaral.
Okay.
Yeah.
Those two paragraphs are yours for the taking.
Okay. So gender, the WHO defines sex as the biological and physiological characteristics that define men and women. Some examples of sex characteristics include women menstruate while men do not. Men have testicles while women do not. Women have developed breasts that are usually capable of lactating while men have not. That is according to WHO 2017b. While gender refers to the socially constructed roles, behaviors, activities, and attributes that a given society considers appropriate for men and women. For instance, gender differences include, in many countries, women earn significantly less money than men for similar work. Also, in most of the world, women do more housework than men. In circumstances where a woman is confined in the home as a housewife, they will have limited or no income. They will need to rely on their husband for money to enable them to access health services such as family planning services. In reality, the husband may not be supportive of use of family planning methods. Conditions of poverty which several women find themselves in can force some of them to engage in transactional sexual relationships with the resultant negative consequences such as unwanted pregnancies, STIs, including HIV. Then the second paragraph, in many patriarchal societies, women generally may have less access to resources and opportunities such as land, education, and income than men. In many societies, children and infants of women with less or no education, for instance, are more likely to die due to preventable causes than those of women with higher education. In some patriarchal societies, women need the permission of their husbands to seek health care and receive treatment. This leaves many unable to access health services. In some societies, reproductive health services are not expected to be sought by unmarried women and are regarded as irrelevant for men, and due to these reasons, are not utilized by these categories, which negatively impacts on health outcomes for these categories. Harmful traditional practices such as female genital mutilation, early marriage for young girls also lead to poor physical and mental health outcomes for many women who experience these practices. Do I
You're going to continue.
Okay. But also due to various forms of masculinity, in many societies, men engage in behaviors that are directly or indirectly harmful to their health. Scrambler in 2008 has described several social factors that explain higher mortality rates among men, as including employment. And about employment, more occupations typically followed by men involve direct risk to life, such as operating dangerous machinery, serving in the military, and fishing. Then the other one is risk-taking behavior. Men are more socialized to participate in dangerous sports like motorbike racing, rugby, boxing, rafting, etc. Men are at a higher risk of road traffic injury and tend to drive more and faster when under the influence of alcohol compared to women. That is also according to Scrambler in 2008. Then more men than women are likely to die during wartime as they are more likely to serve in the army. Then another one, we have gender norms on acceptable behaviors also influence men's and women's health-seeking practices. Sickness, the expression of pain, weakness, and vulnerability that contradicts the masculine ideal. Men feel pressure, therefore, to dismiss their healthcare needs, display strength, and avoid or delay seeking healthcare. Women are more likely to seek help for physical and mental health problems. According to Stavropoulos, 2019. Then the other one, we have smoking. In a developing country like Uganda, men are more likely to smoke than women. That is according to Uganda Bureau of Statistics and ORC Macro in 2001. But in several high-income countries, the gender gap between men and women in regard to smoking has narrowed in recent years, according to Scrambler 2008. Then another factor is alcohol. In several societies, men tend to drink significantly more than women in all age groups and are more likely than women to drink heavily regularly, according to Scrambler 2008. Drinking is typically seen as the demonstration of masculinity and therefore more normal or permissible for boys and men. It is particularly linked to male willingness to take risks or the male perception that alcohol enhances sexual performance, according to Stavropoulos 2019.
Okay, thank you. We're coming towards the end of the meeting today. So we are talking about issues to do with the gender, socially constructed differences between men and women. We also noted that generally men tend to live a shorter lifespan, a shorter life than women on average in nearly all societies. There could be biological explanations for that, but there are also social explanations for that, and that's what we've just been talking about here. Sharon is coming in at 9 when actually the lecture is supposed to end at 9, but all the same, she's welcome. So there could be biological explanations for why women tend to outlive men in most societies, but in this course we are giving emphasis to social factors that explain why women live longer than men. I'm not sure why these students are coming in at this time when we know that we're supposed to end at 9. So men tend to smoke more than women in many societies. Men tend to drink lots of alcohol than women in most societies, and that in one way or the other translates into higher mortality, because die in accidents, die in raiding border borders, you'll find more men there. Higher risk occupations, you'll find more men there than women. So there are going to be a vast array of social factors that explain high death rates amongst men than women. Questions, comments? Questions, comments before we call it a day today? There's somebody.
Dr. Mine is a supplement.
Okay.
This is from a pharmacological perspective that about alcohol. Men tend to take a lot of alcohol, but for them, they have low chances of getting drunk, or they don't get drunk easily compared to women.
They don't, we appreciate that men don't get drunk easily. Like I told you, I've been reviewing lots and lots of alcohol-related literature recently. And then the classification for heavy drinking, for instance, for men is 5 bottles. For women, 4 bottles. But even when we look at that classification for heavy drinking, men gulp quite lots of alcohol than women. So you go around the trading centers in the cover and see those who are the majority of the people who are drinking themselves silly and staggering. Even at this time, you'll find more and more of them are men. So that doesn't negate the fact that we know that there are differences. So they tend to be more risky. And even when we're thinking about health-seeking behavior, or more women tend to seek health services much earlier for a number of conditions, including physical and mental health conditions, than men. Men tend to report late. Many times, several years ago, I used to see that even in HIV clinics, men would come in when they are late. And the treatment outcomes for those who present early and those who present late tended to differ, because when one comes in late and they are in a wheelchair, they might not be able to respond much better than a person who came in walking by themselves. So let's call it a day for today. We're going to meet tomorrow, 8 a.m. Those of you who are not sure of the starting time and show up at 9, the starting time is going to be 8 a.m. And hopefully I'll we'll finalize the summary that I have to provide. And after that, Rachel will also summarize. Rachel, you don't need to worry. We have summarized what you needed to summarize. Just summarize what the document you have talks about. You'll find that there will be some differences in what we regard as social determinants of health. That's still quite okay. Just summarize the document that you have before you. Don't worry about the summary that we've just we are going to finish quite soon. So those two documents need to be read together for a good comprehension of social determinants of health. So thank you so much for showing up today. We meet tomorrow at 8.